Good evening, everyone. And my name is Paulo Jesus Pangilinan. I am from the Philippines, and I am representing Sebaris Clear Aligners. And we're going to start with our case storming session. So I personally love to call it Sebaris Afterwork series. I mean, it works in a context that after we work with some cases, after we see our patients, the idea is that, I mean, let's just sit down, sip some tetarik, sip some tea, have some roti right beside you. So if you guys are chilling right now tonight, I highly think that, I mean, sharing the botch up, sharing the difficult cases, it's a good session to talk about whenever we go to a mamak shop and have some tea and have some food. Okay, so good morning, good evening, or good afternoon for everyone who's watching here. I'm live in Kuala Lumpur tonight, and this topic is something that is very special for us because these are cases that are actual cases that we are seeing from day to day. So the concept of a case storming session is I'm just presenting whatever we have discussed or whatever we have found out. And the structure is we are bridging the clinical aspect together with uh the theoretical aspects of clear aligner treatment and what can we do about it when we're going to tackle cases in the future? So if you see your case here, definitely this is something that we might have talked about late at night or early morning, whenever it's bothering you. That's why I call it after work sessions because most of the consults are happening after work or right before they go to work. Okay, so in this topic, we're going to talk about concepts in simulation reviews and our considerations whenever we're going to look at our cases. So, case categorization of your cases usually goes with basic principles of clear aligners. Now, we have to understand that clear aligners are tools, and in Sibarius, we are not just focused on doing clear aligner treatments, but rather we welcome complexities of every cases, and we accept that Sibarius or clear aligners in general are merely tools. Now, we welcome fixed approaches, we welcome hybrid approaches, we welcome any type of approaches that would make treatment much better. Now, Sebaris, in a sense, is that, or the way we do things with Sebaris is we are heavily invested on your diagnosis and treatment planning, and we're just a company who makes aligners, right? So, in terms of case categorization and case assessment, the idea is something like this. The higher the category of your problem is, okay, the higher category of your problem is, of course, the predictability becomes lower. Now, when we talk about predictability, it's not that your treatment is not going to be effective. The context of predictability here is when once we say that something is not as predictable, meaning that the movement that we can design is a little bit complex. Now, it doesn't just work with your clear aligners, it also works with any orthodontic procedures. There are cases where you might need to modify your wires, i.e., wire bending, so that you can fix the position of your teeth, right? Similar to clear aligners, there are cases where sometimes it doesn't go as planned. And the reason why it doesn't go as planned is there are factors that are actually involved. Now, having that said, the decrease in your predictability also require you to consider auxiliaries. And it goes without saying that, again, clear aligners are tools. And it's good that if some practitioners can finish clear aligners without any auxiliaries at all. Uh, but you have to welcome the need for auxiliaries because, again, you have to understand that for every movement that we do or for the complex movements that we want to do on some cases, we might need to welcome these thoughts eventually. Okay? So once the predictability is a little bit low and the need for auxiliaries is a little bit high, in your thought processes, whenever you're going to look at your cases, look at your simulations, look at whatever that is on your simulation platform, you have to get good anticipation for troubleshooting and refinement. Now, I think in our platform with Dental Tribune, if you have any questions, you can actually type it in space right below, and we're gonna answer it right at the end of the session. Okay, so yes. All right, so I have one question here already, and is Sebaris a direct print aligner? We are not yet exploring the world of directly 3D printed aligner. We're still using a thermoformed ones. The reason being is we wanna stay first on a much more established science, but don't worry, we welcome it as long as we have the right evidences and the right clinical, right clinical predicament to execute it. Okay, yeah, that's good. All right. So the question is something like this: how can we strategize our treatments? Now, usually, whenever you're gonna look at clear aligners, there's always this concept of, is it going to work? Is it gonna be predictable? Now, if we're gonna look at strategy, strategy actually starts with doing the predictable movements, and we anticipate difficult movements. And that's the reason why we have simulation reviews. Now, doctors, you have to understand that your simulation reviews are just representations of your treatment objectives. Of course, you have to understand that actual clinical results may vary because we can plan with the best physics combinations possible. But of course, once we execute it inside the patient's mouth, tissue reaction technically varies from patient to patient. Okay? So, one study that I really love going back into whenever we're going to talk about predictability is by looking at the amount of predictability ratio that is right here. Now, turns out that 88% of distalization cases are technically predictable if it goes within 1 to 2 millimeters of distalization. Yes, but of course, these are predictable values with inclusion and exclusion criteria. Doctors, you have to understand that there are certain things that we also have to recognize. I mean, yes, by physics, it's going to be predictable, but of course, case selection is also important. Even if in clear aligners, expansion is very much predictable, if you don't have enough bone, of course, it's not going to be a good idea to start expanding your cases. Now, doctor, the work of your aligners is just executing it. It's just delivering the forces. At the end of the day, your teeth doesn't know whether you're giving fixed appliances, you're giving them wires, you're giving them rectangular or round wires or aligners or the most expensive brackets in the world. What your teeth will recognize or what your body will only recognize is the force that you're giving him. Is it optimal? Is it low? Is it high? And the force is gonna respond depending on the tissue that is within it. If you have bone, if the length of your root, the density of your bone also goes into picture. Okay? So it's not just the activations, it's also the tissue reaction. All right. So the context of predictability, and before I go to two cases that we're going to do a little bit of case storming tonight, the basic principles of clear aligner treatment is something like this. Aligners push teeth, fixed appliances pull. We can program multiple movements, meaning for clear aligners, we can do tipping, or we can do leveling and alignment together with torquing, because we don't have to wait for a rectangular wire for us to complete it. So meaning we can plan multiple movements for clear aligners. Now, it doesn't go like we can plan LNAs, leveling and alignment, space consolidation, finishing all in one go. It's nothing of that sort, but rather we can plan three-dimensional movements from the get-go, because the force that we're gonna deliver is technically optimal based on how you're gonna program your every step. Now, third principle is basically anchorage is required for efficient tooth movement, and it goes with Newton's third law, where for every action, there's an equal and opposite reaction, and the law of inertia. That we have to understand that all appliances in the world, eventually, it's just gonna go to equilibrium. So meaning, doctors, if you recognize, like on your aligner cases, if you recognize that, hey, I programmed 2 millimeters, but how come I only get 1? It's because of the law of inertia, meaning that your body tends to deactivate the forces that you want to deliver. And that's a truth in physics. Every appliances in the world tends to deactivate or tends to go to equilibrium. Okay? So it's something that we can recognize. All right? Now, fourth principle is space is required for teeth to move. And the fifth principle is overcorrection and programming should be anticipated for effective treatment. Now, doctors, these principles are actually the guiding light or the guiding steps towards a successful clear aligner treatment. Now, it may sound so simple, doctors, but as you see these two cases that I'm going to present later on, the issues for refinement actually boils down to it's not a violation, but uh, any error within these five things. Okay? It's actually rooted to these five key principles. Now, whenever we're gonna do treatment plannings, and for our alumni who have been with us, or currently watching with us, and when we consider treatment planning, is the first step is we don't align or move every single tooth in the correct dimension. Of course, if there's no anchorage and there's gonna be no correct movement. So meaning on your aligner treatments, you have to look at how it's gonna be planned out. Number three, if there's no need for movement, don't move tooth or teeth on your simulations. Meaning on your simulation, you should not see it moving. Now, the idea is something that your technicians know how to activate to make sure that this teeth doesn't literally move clinically. Number four is one of my favorite considerations because noting your biological limits. Now, have you ever wondered why when you distalize, it doesn't distalize fully, but rather it just tips distally? It may be because your lingual cortical bone is already exhausted or you don't have enough posterior available space to operate. Now, the fifth one is you have to note on your accumulated movements because now this is the beauty of clear aligners. Right now, in this era, studies now from the past, they're doing a lot of studies revisiting multiple simulations, multiple clinical results, and they have actually came up with some values on accumulated movements that are deemed predictable and that may be deemed moderately or not so predictable. So yeah, so the science now is growing and it's growing at a faster rate. And number six is we're going to look at your vertical dimension and your final occlusions. And number seven, we consider auxiliaries pre-treatment and or mid-treatment. So whenever you're going to plan your treatments with clear aligner therapy, this is something that I always want to refer to, or I always want to go back with this one. Now, the cases that I'm going to present on the following slides, okay, then the cases that I'm going to present, these are cases that we have been working on. Now, I want you to look at these cases not on how they were finished, but what are the things that we have learned? Okay, what are the things that we have learned to make the treatment be as clinically acceptable for the patient and for the science as well? So, let's now start with this first case here. Now, this patient presents with a kind of short vertical height. Now, if I'm gonna turn in my laser pointer here, you're gonna see that okay, this patient, when patient smiling, it doesn't have a nice smile arc. There's a dark buccal corridor going on. Profile is quite acceptable. Now, based on the pictures, it's kind of leading us towards a class 3 kind of relationship or an edge-to-edge kind of relationship, which we can see here on the extraoral photos. Now, if we're gonna go deeper into it, what we're seeing here is a negative overjet. Now, yes, definitely the midlines are somewhat coinciding with a little bit of deviations, which can be fixed with some leveling and alignment. What I'm seeing here is the canines are in somewhat a class 1 to class 3 kind of position. The lower arch is a little bit constricted, as you can see, and the upper arch is a little bit okay. And there's some mild anterior crowding, and your anteriors are actually back. Now, if we're going to look at the possible etiology of this malocclusion, It can be because of how the patient has been growing. It can be the mandible has been growing so much, or it can be there are habits as well. But one thing to note is that once, because your lower anterior doesn't have any contact on the anterior, it tends to find an opposing. I mean, that's the nature of life, or that's the nature of your body, where this one is going to supra erupt or this one's going to extrude. Therefore, I mean, problem wise, it's something that we have to intrude. So what we did is we looked at the panoramic radiograph, or TOPG, and it's interesting to note that we have, okay, if we're going to look at, if you're thinking of potentially we can distalize this case here, perhaps we can utilize, okay, I'm seeing a good posterior alveolar space here, perhaps I'm going to distalize. Now, the problem here is if I'm going to distalize, if I'm going to go back to the intraoral photos, if I'm going to distalize, I might ruin this. So, as you can see, doctors, I'm looking at principle number 4 already, which is space is required for teeth to move. Now, whenever I'm looking at these cases, the first question that I always ask is, how am I going to create space? How am I going to bring this out? Now, of course, the easiest answer is for me to just procline this one, let it jump. Now, it sounds simple, yes, but we have to look a little bit deeper. Okay? You have to look a little bit deeper. Now, when we look at his cephalometric tracing here, we have a low vertical height. The FMA value is 17 degrees. Normal is around 25. Based on our Ceph values here, our SNB, or our skeletal relationship is technically a skeletal class 3. So we have a skeletal class 3 phenomenon here and a low vertical height. Now, our lower anteriors appears to be in a more proclined position, meaning, of course, if we're going to look at it on a treatment planning level, we have to recline that to bring it in. Now, it makes sense. Now, here's the problem. When we did the measurements, upper 1 SN turns out to be proclined. So, I am stuck on a dilemma whether, okay, what am I going to do here? Am I going to just procline the upper anterior and let it jump, or should I do something else, or can I just increase it a little bit more? Is it okay? Is it going to be fine? So I think you are going to be sitting on that same dilemma here where, doctor, how am I going to fix this now? Sagittally, it looks okay. It's towards class 3. Okay, it's towards class 3. But I can't afford to extract, because this patient's not going to look good whenever I'm going to do extractions. So I'm stuck. You're going to be stuck on that dilemma. I mean, if you feel like you're stuck, it's perfectly normal. It's quite okay. I was stuck. We were stuck. Okay? During that time. So, what's our thought process now? Knowing that we have this, a class 3, a slightly class 3 patient. Okay? But with a short vertical height. We are looking at the potential thought process that, yes, we might not need procline the anterior teeth so much forward, but we can increase the vertical height a bit. Once we increase the vertical height, your vertical height is going to increase slightly. It's going to go downward. Your mandible is going to go downward and back. So from a class 3 relationship like so, it's going to downward and back. It's going to end up with some class 1 relationship. Now, vertically, yes, we have the solution. Sagittally, yes, we can expand to develop the spaces that we need. Of course, we can do that. But how can we somewhat increase the vertical? Increasing the vertical with the aligners itself is quite enough, because it's going to give us some disocclusion. But we have to be a little bit more intentional on how are we going to raise the bite. So here's what we did. This is the initial simulation. Okay, here's the initial simulation. And what we did here is basically the first elements. Again, we work with space creation. Once we did space creation, we just have to bear with the collision happening there. Okay? And as you can see on the occlusal area, there is a bite racer. There's a bite turbo there to increase the bite. Now, here's a problem of some simulations where it's hard to represent the total amount of the bite that's going to increase. Okay? So, total amount of bite is going to increase. So, the way it looks like this one, okay, the way it looks like at this point is we're just going to jump the upper anterior, utilize the space creation techniques of expansion and proclination to actually bring it out. On paper, it looks good. On simulation, it looks good. Now, here's the thing. Okay? So expansion and proclination. So here's the thing. We executed the treatment. Okay? We placed bite tracer on the lower. You can see it here. Okay? We're somewhat expanding and intruding the lower anteriors because based on what we see there, based on our diagnosis and our problems, it's where it's going to go to. So it follows the principle that aligners are going to push. It's going to push from behind. We have anchorage. We considered our vertical heights towards the end, and at the same time, we go with proclination. Now, here's what happened. It's initially scheduled for 30 steps. Now, we can finish it on step 30 and then go straight for refinements. But what we did, or what the doctor did, is basically we stopped at step 22. Now, on step 22, this is what it looks like. Now, when you're gonna review, when we are reviewing our cases, it doesn't require, I mean, you don't have to take a scan more often. Most of the time, photo comparisons is just okay because guys, you have to understand that your clear aligners, your treatment simulations are representations of what you want to see on clinical. Okay? And the way it's delivered, it should somehow match or be as close as possible to the treatment simulation that is presented. So this is the position at step 22. We have increased the vertical dimension. Of course, there's going to be a little bit of open bite on the posterior because of the bite turbos. And we managed to somehow jump it at step 22. Now, what's the reason why it didn't proceed to step 30? The reason is, if we're going to look at the simulation again, okay, if we're going to look at the simulation again here, what happens on, okay, what happens on step 23 onwards is something that would go against the treatment objective. As you can see, as it goes beyond step 23, it starts to retract. Okay, so even if we're reaching that objective, perhaps we could have just continued on the proclination, maintained that position, and perform overcorrection on the lower anteriors. So, but as you can see on this simulation again, once it proclines, okay, because it creates space. So any residual space detected on the platform, what it does is it's going to be constricted so that it can close any residual spaces. But the problem is, on the progress, we don't have enough residual spaces and it doesn't make sense for us to retract it even further. Okay? So what we did is we went for refinement. So what's the thought process? So we don't wait until the aligners are actually finished. Because again, at the end of the day, the aligners are delivered in batches. So it's not that 30, we sent 30. It's just that we're sending by sets of 5. Now, knowing that, okay, at step 22, we're gonna go for refinement, looking to save on aligners and be more efficient and be more effective. So here's what it looks like on step 22. Okay, you can see that there can be there's a little bit of increase on the vertical height, and at the same time, it has a much better showing. A little bit of expansion has happened. Position of the teeth is much better. But as you can see here, going back to the principles here, this crowding is a little bit difficult to address, mainly because on principle number 4, that we need space for the teeth to move. So perhaps we can expand a little bit more. We can work with the posterior open bite here. Now, looking at this case, if you're gonna look at it, the easiest answer is, okay, fine, let's just close the whole thing. We have the bite turbos here, which which was removed during the entire thing. I mean, which was removed during the refinement stage, but this one here is the cause why we have a posterior open bite. So what's gonna be the solution now? I'm gonna switch to the simulation, and this is something that is currently still work in progress. Now, here is the simulation. Okay. Immediately, the cause of the posterior open bite, if you're gonna see here on the mandible, there's no more bite turbos on step 0 on this simulation. But what you're seeing here, doctors, is if I'm gonna zoom it in right here, and if we're gonna go to the maxilla, we turn on occlusion. Immediately, guys, what you're seeing here is there is anterior interference. Now, the presence of anterior interference on our treatment planning considerations on vertical dimension and the final occlusion, the idea for us is to actually finish our cases with a 1 millimeter overbite and overjet. Ideally, as much as possible, as much as we can, we have to finish there. But bottom line is, on our anteriors, we should not see any contact at all. So, what have we done differently this time around? So if you remember the initial simulation, on the refinement stages, on the upper, it's going to be like 5 steps. On the lower, it's going to be 18 steps. Now, here, what you're seeing here is on the lower, we are much more intentional towards the intrusion, a little bit of rotation on suit number 4-2. And the idea is to remove all the premature contact on the anterior. So what happens is if we remove the premature contacts on the anterior, where will the mandible go? It should somehow close slightly. Okay, it should somehow close. Okay, so this is the treatment objective. All right, so now if we're gonna see the entire simulation here towards this area, although there's a little bit of interference here, but of course we are looking to somehow procline it a little bit more. Okay, so this is what it looks like. So in clear aligner therapy, doctors, it's still fixed. When I want to change, or I'm not changing, or I'm just reinforcing the definition of refinements. When you say refinements, it's something that is not bad, or it's something that is not desirable. In fact, refinements are something that would allow you to correct your course or reorient your course or your treatment. I mean, for fixed appliances, if you change the position of your bracket because on your initial stages, it's not that place on the right position, you change the position, it's technically termed as refinement. If there is a seat that doesn't follow what you want to do on fixed appliances, you did the wire bend, you did a step up, a step down, it's also called the refinement. Now, clear aligners is not different. It's still orthodontics, meaning refinements can actually happen in the middle. Okay? So, in this case, in summary, patient has worn, okay? In summary, it's worn 22 steps, okay? The refinement is going to be 5 steps in total. So therefore, instead, okay, here's the good thing. Instead of a 30 aligners, because the objectives were met and we did not need the other 7 steps or the other 8 steps from the previous simulation, the refinement steps technically decreased the total amount of aligners from 30 to 27. We saved like 3 aligners. However, since there is some space issue, there's some overcorrection, principle number 4 and principle number 5 is not yet fully met. Lower will have 18 steps, or technically from an initial 30 steps, there's going to be 10 additional steps so that we can finish. So the idea of that one is to incorporate overcorrection. So the plan is still tracking. I mean, if there is one, we're gonna post it in our closed group channels if there is a conclusion for this one. But I want you to understand that these are the cases that is currently in progress, and I want you to understand the idea of how do we find the cause and how are we gonna go with the refinement cases, or how are we gonna approach some difficult cases as well. Now here, class 3 elastics can also be needed to have vertical control. And the bite turbo at this stage, we don't need it anymore because if we keep the bite turbo after this simulation, okay, imagine this one. If we did the intrusion and the bite turbo is still there, it's gonna end up with an anterior open bite. So we want to remove the bite turbo because the height objectives has been reached. I mean, basically we have made the jump. It's just that we're just gonna reinforce it a little bit more. Okay? So class 3 elastics can be needed to have vertical control, and bite turbos can be removed. So I have a question here on our community chat is bite tracer on your posterior teeth. How you place the bite tracer on top of the aligner? So doctor, the bite tracer is actually programmed, meaning on your attachment template, okay, on your attachment template, there is actually a space there where you can place your bite tracer already. Okay? And on your aligner, it's just enough for you to act. Your aligners are technically going to cover that area as well. So, doctor, why have you placed bite tracer? I mean, can you just incorporate bite tracer on your aligners? Well, the answer is something like this. Okay, you have to understand that one of our main objectives is to increase the vertical. Now, once the patient removes the aligners and knowing that we're proclining the anterior, it can cause some trauma on the anterior as well. Okay, so it's gonna have some hard time. It's gonna have a hard time for your anteriors to actually go out, to actually procline, knowing that the lower incisors are gonna interfere sagittally. So if we're gonna increase the bite slightly, okay, increase the bite slightly, we're giving the small clearance for your upper anteriors to actually jump with or without the aligners. Okay? And besides, the bite tracer is gonna benefit our vertical costs. Now, let's say if the patient is a high vertical height, of course I'm not gonna place bite tracers there. Okay, of course I'm not gonna place bite tracers there. Or I might have incorporated the bite tracer from the aligner itself. Okay? So that's the whole idea. I mean, yes. Okay. So here's another question. Did you have to remove all existing attachment before rescanning for refinement? This is actually a good question. Now, for refinements, okay, for refinements, the idea is something like this. You have to understand that the way we treat refinements is something different. Okay? Now, if your attachment it's still gonna follow the same treatment objective where the attachment is intended to be, you may not remove it. Okay? But if you're quite unsure based on the new objective that you're gonna set, if it's still the same attachment, and if you have doubts whether will this attachment be as efficient, I suggest you remove them. Okay? I suggest you remove them. Because if you don't remove them, okay, if you don't remove them and you let your planner just perform an attachment, an attachment right on the tooth, what happens there is it may have some trouble fitting. Okay, it may have some trouble fitting, or it may not deliver your forces as adequately as possible. Okay? Okay. So that's the summary of the first one. Now, I love the questions here, and this is something. Yes, I mean, I'm expecting this kinds of question because these are the cases where it's like you're sitting on your chair. Oh yeah, I have that kind of patient. I'm experiencing that kind of patient now. Yes, of course. Yes. All right. So let's go to the next case. If you still have any question, we can always go back. No worries. But here's the next case, and this case it has a very long journey. Now, this patient is complaining of a crowding, anterior crowding. And of course, the way we're going to look at this one is, okay, patient has crowding, patient has a deep bite scenario. We have a lot of issues here. But we have a class 1 relationship. Now, if you're sitting there and you're looking at your potential treatment planning, or okay, why not I just extract? It's actually a possibility to just extract. You can see the incompetence of the lips. We can actually extract all the force, make it easier for us, somewhat change the profile slightly, and it's quite good. Now, here's the problem. Patient doesn't want extraction, and we have to make do. Okay? Now, in these kinds of problems, I mean, if these kinds of cases, basing on our case categorization, based on the treatment predictability, we all know that plastic is going to experience a whole lot of plastic creep here. So as doctors, when you see cases like this, can I treat this with clear aligners? The answer is still yes. but you have to understand that on this region, you have to be much more particular with space creation, okay, and plastic creep and overcorrections as well. You have to be very, very smart on how are we gonna go about with this one. Now, it's not in the context of doing it with less aligner possible, but actually doing it with the most efficient approach possible. Now, this case agreed for clear aligner treatment. And if we're gonna look at your OPGs here, we have impacted third molars. Basically, the amount of teeth or the quantity of the teeth is not enough for the quantity of the bone. Uh, that's why we're looking at any potential ways to do extraction. Okay. So on his lateral ceph, this is also a good news for us because since we have a deep bite, FMA and SNMPA is actually quite low. So meaning an increase in the vertical would technically benefit this patient. Now, we have a normal maxilla. Mandible is quite normal, but skeletally, we have a skeletal class 2 going on. So, we are here at the dilemma where we might need to perform extractions for this patient. I mean, but unfortunately, patient is not keen on doing extractions. But the way we look at this one, all right, the way we look at this one is we have sufficient bone here to actually accommodate some form of proclination. I am looking at space creation opportunities to develop the space that we need. So I can do expansion, we can do rotation, we can do proclination. Okay, we can definitely do IPR, right? But is inside lower incisor extraction an option? I think it is, but I want to keep it as one of my last cards. Okay, but yeah. So here's how the simulation goes. On the very first run, okay, simulation goes like this. It manages the case head on. It's actually scheduled for 56 steps. It actually, yeah, less than 60, but more than 55. But yeah, it started off with space creation of expansion, some proclination and some rotation going on as well. But as you can see here, there's a lot of challenges here on the lower. Uprighting this one is gonna be so unpredictable, right? There's gonna be some predictability issues here because we have to understand in uprighting, okay, in uprighting your premolars, your canines, and your molars, it's one of the challenging movements in clear aligner therapy. Okay, so here we're doing retraction and proclination, and these are one of the cases where we don't have that much experience yet. Basically, we're just letting it flow. I mean, we did our best during this period. We think that this is the best simulation to do it, or this is the best way to treat this case. But as you can see on this simulation, we have no choice. I mean, basically, there's a lot of collisions going on. We're technically forcing it in. Okay, so this on the upper, we're doing expansion. We're doing some rotations. Okay, these are forms of space creation. Okay. And with some residual spaces, we still manage to retract slightly and with the help of a little bit of IPR. Now, here's what happens on the lower. Okay? So if you're going to see the simulation, there's expansion. After expansion, proclination, rotation. And as you can see, doing this proclination right here and on this area, it's going to be so challenging. Forcing it out like so, uprighting it to go here. We know that in this simulation, this is gonna be the pressure point. Back then, we didn't know. Back then, we didn't know. We didn't know better that time. So what we did is we proceed with this treatment. Okay, we proceed with this treatment. Patient's about to finish the entire steps, and this is what the patient looks like. Okay, upper, everything looks okay. Now, knowing that we have some problems on the lower here, vertical issues is still there. treatment objectives on the upper is somewhat right there. We have the space here, as you can see, based from the proclination. All it needs now is a little bit of retraction. The objectives of the simulation on the upper is met. But doctors, this part here, most difficult one, something that didn't move. So if we're gonna look at this one, or what have we learned from this case here? We have actually looking at the principles of clear aligner therapy. And based from this simulation, or based from this result in this refinement, we have technically violated principle number 4 and principle number 5. Space is required for teeth to move. So meaning we should have prioritized space creation on the 4-3 and the 4-2 region so that we can align it as sufficiently as possible. Overcorrection and programming should be anticipated for effective treatment. Now, as you can see on the pictures that we have here, in the staging of your deep bite, we have to procline and intrude. What we did here is something that where we stick so much that doing proclination and then doing intrusion. Now, based on the predictability threshold that we just knew, intruding it alone is something that is not so predictable. But what is predictable is doing your intrusion together with a much more predictable movement. So when you procline and then you intrude at the same time, it's not an absolute intrusion. It's a relative intrusion in some sorts. But you meet your objectives because it's a secondary nature for your proclination to actually intrude the teeth. So it's something that we should have utilized. Okay? And this is something that we did on the second simulation. So, but before that, we went to the refinement notes here, where we went towards the next simulation, which is right here. Okay. Okay. So with the same problems that we have here, looking at the occlusion, okay, on step 0, we don't have good occlusion on the posterior, mainly because, again, we have anterior interferences, which is kind of expected for these kinds of cases. You can see that we have posterior open bites all over here because of this anterior interference here. Now, if I'm going to just zoom it in and just going to play the video. For the upper, the solution is quite straightforward. Since we have space and since we have anchorage, all we have to do now is just finish the entire case and let the overcorrection set in. Now, as for the lower, let me just turn this down. Okay, let me just go here. The concept is something like this. Performing IPR to create that instant space. If we were to do it again, okay, we should have performed a little bit of IPR here on the premolar, distalize it a bit to generate a little bit of space here. And then once the interproximal contact of 4-3 and 4-2 are together, this is the time we did IPR. So again, during this time, we didn't know better. Now we're just learning, we're just improving a whole lot of things. So in this sense now, we're just positioning a little bit of expansion, some intrusion for 16 steps. So here's what it looks like. Okay. So some relative, as you can see here, it now has a relative intrusion. It now proclines and then intrudes. So basically, we learned from the issues from the first simulation. Okay, we learned. Okay. So if we were to do it again, we could have had a simpler, or we could have an easier refinement if we know some of these things earlier on. But since we didn't know, we have to go through this process. So right here, right? So what have we noted here? On step 16 of this particular refinement, this is what we were left with. We are kind of expecting that the lower anteriors now are gonna be on the right position, at least. Okay? But again, it's still principle number 5. This is where we recognize the value of overcorrection. If you're planning to intrude 1 millimeter, on your simulation, it looks 1 millimeter. Net movement is usually within 0.5 or 0.4. So what should we do now? This 1 millimeter movement now should have been overcorrected by another 1 millimeter more. So meaning on your simulation, it should look like a little bit of an open bite, which should be a little bit normal. It should be normal. Okay? So, but the good news is, from the first case, is we managed to make it as close as possible, mainly because of the space that we have created. So as far as principle number 4 is concerned, we are quite there. And of course, the upper is just as tracking. Now, the reason why the ending is not yet so satisfactory because of this one is because, again, a little bit of issue on principle number 4. There's a little bit of space issue here. Perhaps we should perform a little bit more of IPR, okay, on this patient. Okay. And we have technically maxed out the expansion. So perhaps we can move on to the IPR on the anterior as well. So here's the simulation on the third try. So here's the third attempt. Here's the next simulation now. Now, from a 16 aligner simulation, now it becomes 16. Okay, from a 16 simulation, and now it becomes 13 on the upper, just to finish the whole case. And then 15 aligners on the lower. So as you can see, it's actually a lot. Okay? Because the case is advanced by nature. So again, as I've said, if it's advanced by nature, the predictability on some movements is going to be low. Okay, it's going to be lower. But you have to anticipate some refinements or mid-treatment corrections going on. So this is one of those cases where it's not always rainbows and butterflies. This is the reality of life. I mean, there are cases where you're going to see something like this. Okay? So, but the concept here is it's not how you start, it's how you improve, or it's how you actually manage it from here on out. Now, here's the simulation. A little bit of proclination, a little bit of intrusion on the upper anterior, and then just consolidating the space a little bit further. We drew the last point of IPR here. Okay? And now on the lower, like so. As you can see here, on step 11, the plane of occlusion is quite satisfactory. But what we did here is we intruded it a little bit more. Because we've learned principle number 4, we need space. So what we did is we generated the easiest space that we can think of is right here. Okay. And then just a little bit of occupying the residual spaces all around. And that should be enough. It should be enough to actually give the torque and finish the whole case. Okay. So on that simulation, okay, this is what we were left with. Okay. Going to this one, this is what we were left with. We're now in class 1 canine relationship. Okay, a little bit of posterior open bite because of the anterior interferences as you've seen on that simulation. But yes, if we're going to look at the objectives of this simulation here and with the amount of overcorrection, we are on a track to actually finish this case. Now, some refinement notes though. On this refinement simulation, even if it's the second, or technically it's the second refinement already, overcorrection should be intentional and space creation should still be intentional because those are the root cause of the problem. Okay, so meaning when you're going to look at refinements, whenever you're going to look at refinements, it's not that your teeth movement is not efficient. It can be a violation of one of the 5 principles. Okay, you should have been you should have been thinking that aligners are pushing. You should have been looking at anchorages. You should have been looking at multiple movements can actually be done. So example is that intrusion where we can procline and intrude at the same time. That's a form of multiple movement that is much more predictable than just in proclining and then intruding, because the proclination part is predictable. The intrusion part is something that is not predictable. We should have just coupled them together because we can overlap or we can utilize the side effect of a proclination to actually intrude. Okay? Now, space creation, of course, for the 4-3 and the 4-2 area, it should have been much more intentional from the start. We could have prevented some severe refinements if we could have just notified that one. But doctor, are refinements inevitable for these kinds of cases? My answer is yes. Because by nature, it's going to be some form of advanced. Now, as I've said, the higher the category is, the lower the predictable is going to be. Okay, the lower the predictability is gonna be. Therefore, the lower the predictability, you might need to use some auxiliaries, and you might want to look at other options as well. That's why here are the lessons that we have learned. Now, the upper can proceed with clear aligners alone because based from all the treatment, it technically is just going on track. I mean, it doesn't cause any severe issues. But the reason why we have these two kinds of refinements here is because the lower is the one that's causing the refinements, particularly for 3 and for 2. And knowing that that is my scenario, I can use clear aligners, yes. The principle of pushing still apply as long as I follow the other principles as well. But perhaps using a fixed appliance to initially decrowd can actually be used. I mean, initial decrowding just to procline, just to align them together. And once they're aligned, all we have to do now is perform IPR and then pull them back. We could have saved a lot of aligners there. We could have saved time. Okay? We could have saved time in treating this patient. Okay? So yes, that's all for the cases that I would love to share for tonight's case sharing. So I'm gonna look at some questions here on our in our interaction board. Okay, so one question here from Dr. Albert regarding attachment removal during refinement. Can the planner enlighten us on which one needs to be changed in order to get better outcomes instead of we remove all the things prior to scanning for refinement? Okay, that's a good question, doctor. Now, going for this case, for example, doctor, let me give you just a quick example. Now, if I'm going to look at the attachment on 1.6, 4.6, 3.6, and 2.6, regardless if I am going to move anything on the anterior, am I going to remove my attachments here? My answer is no, because at the end of the day, this follows principle number 3 that it needs anchorage for correct movement. So meaning, the attachment here is I'm not going to remove it. Okay, I'm not going to remove it because it's something that I might use, or that I'm going to use for anchorage purposes. I mean, it doesn't make sense for me to remove this and then on the simulation, the same attachment is going to be back, right? And also, the reason why most of the refinements are getting much better results. There's been a study a few years back that that suggests, okay, it's just a suggestion that placing your attachments beforehand and then you perform a rescan and then you submit it for planning turns out to give better aligner adaptability, because usually there is around a zero point 0.5, an average of 0.25 to 0.5 millimeter deviations on attachment placed with a template. Okay, and sometimes because of that deviation, there are some movements that are that are executed some inefficiently, causing you to have some problems as well. Okay, now, yeah. So again, this is a good example. The doctor did not remove the attachments on the 6s because we know for a fact that this is an attachment that we're gonna use eventually. Okay, so based on your movement, if your teeth is gonna procline and you have an attachment that can go the other way, you might as well remove it. Okay? Yeah. Okay. Question from Anonymous. In clear aligner cases with traditional orthodontics, do you favor odontectomy of lower eights prior to the start of treatment? Well, doctors, number one, the most important factor for me in extraction of the lower eights is number one, if it's going to be influential to the it's an influence to the etiology of my malocclusion. If it's actually the cause of my malocclusion, I'm gonna remove it. If it's going to be a factor to give me another malocclusion, for example, impacted third molar, second molar is right here. If it's gonna push on the cervical of your second molar, causing it to extrude, might as well remove it. If it's perfectly upright, perfectly okay, and it doesn't cause any interferences at all, any functional things for me, and it doesn't cause any problems for me, might as well not remove it. If the position of this teeth is too far off that we cannot touch it, or it's not gonna disturb us in any way, might as well not much remove it. Okay? So yeah, but again, if it's going to cause you problems in the future, if you perceive, or based on your case selection, diagnosis, and treatment planning, it's going to cause you problems in the future, might as well remove it right before you scan. Oh, here's another thing. If based on my scanning, I'm finding a hard time scanning that third molar there, most of the time, your aligner company is just gonna end up giving you a molar tab, meaning it's not gonna entirely cover your eight, it's gonna partially cover it. Most of the time, it's gonna irritate your patient, so you have to make a decision. If you don't want those smaller tabs, it's either you extract them or let the patient bear with it. Unfortunately, the reason why we place smaller tab is to prevent unwanted extrusion of your third molars whenever the clear aligner are causing interocclusal spaces. Okay? Because what happens if your eights are not covered, your aligners are worn 22 hours a day. That's 22 hours of an opportunity for your third molars to passively erupt. And you're going to be surprised that at one point on your treatment, your eights are a little bit intruded. And how come during the middle of your treatment, it starts to contact first? That is because you have left a space. Okay. Now, here's another question from an anonymous doctor. My case required a lot of interproximal reduction on the lower arch. Is there any guideline on how much IPR can be avoided by extracting premolars, or how much IPR can be replaced by removing the first premolar, or how much by removing second premolar? So I think, doctor, the issue of the question is deciding how to go with IPR or not. Now, doctors, in terms of space creation, all right, space creation actually comes based on a lot of factors. Now, usually the debate is not on the IPR. It's actually whether to perform exo or non-exo. Now, doctors, based on what paradigm you're doing, if you're using a hard tissue paradigm, of course, if all your indicatives lead to exo, don't force your way in for a non-exo approach. I mean, yes, you might have to do IPR, yes, but again, if we're gonna look at numbers here, okay, the maximum number of IPR that you can do is within 0.5 per area. And we don't want to do IPR on the molar area because again, it's going to be very difficult for you to consolidate. And again, clinically, it's going to be difficult for your instrument to go there. Okay? So, yeah. So if your case requires a lot of IPR, maybe you want to look at other space creation modalities. Perhaps consider looking at expansion first. Perhaps looking at doing proclination first. Perhaps if your premolars are rotated severely, perhaps why not just pre-rotate them first so that you're not forced to create instant space to accommodate that rotation. Pre-rotation in a sense is you're gonna place like button on the premolar, place a button on the other teeth, elicit a couple without any activations in, just to make the rotation within predictable limits. It's gonna save you 25, if it's gonna save you like 10, 20 aligners, might as well do it right before you even start treatment. These are called pre-aligner techniques that you can use. Now, expansion, proclination, perhaps take a look at distalization if it's possible. Now, if all those, based on your case selection, diagnosis, and treatment planning, all of them, despite doing so, still going to lead you with a lot of IPR, perhaps, my opinion, there's my opinion only, perhaps consider extraction. Okay? Yeah, because if the total IPR is technically going to be the same value of two premolars already, might as well sacrifice two teeth than damage everyone. Right? Yeah, it's something like that. All right, so here's another question. Thank you, Dr. Albert. So you're shifting from fixed appliances to aligners. Do we need to remove the brackets? Is it possible? If the answer is not, remove it during aligner stage. Okay, this answer I can answer in two perspectives. Okay, now the first perspective is I am going to shift from fixed to aligners because I am doing finishing. Okay, that's the first perspective and that's the first context. The best practice is actually to remove the fixed appliances. Well, your planner can digitally remove your fixed appliances, but you have to understand that for models, the more sculpting, the more modifications they do, the less accurate the fit is going to be. My suggestion, doctor, for hybrid cases like that, where it's gonna be you're gonna finish your case with an aligner. Once you remove the aligner, just issue an S6 retainer. Just give them a clear retainer just to wear while waiting for the next steps of aligner to come. Okay? I do understand that there are some doctors who are looking at just digitally removing the brackets and then just go with it. And I've tried it. I've done it, and I find that there are movements that are a little bit difficult to execute if I'm not using the exact scan. If I'm using an altered scan, I'm seeing some gaps. Uh I'm seeing some issues on the gap of my aligner, which I feel like it's not really hugging the teeth that much. It's not really engaging that much. It does engage, it does elicit the movement, but I feel like it's not so efficient. So that's the first context. Remove the brackets, issue an aligner or issue a small retainer, and then just proceed with the planning to do your finishing. Now, here's another perspective. The other perspective is doing it hybrid, meaning at some point you're gonna do aligners on some, but you're gonna leave a bracket for a segmental mechanics. Now, doctor, this I suggest not to remove the brackets if you're gonna do for a hybrid. You have to inform your planner that this side here, let's say, you're planning to upright a molar, and we all know for a fact that using aligners to upright your molar is gonna be so difficult to perform. So that's why we're going for a hybrid approach where we're gonna place a bracket there. So you place the bracket, you made the scan. Now, what you can instruct your planner is something like, can you just simulate an uprighting of my molar because I am gonna do a fix, I'm gonna do a hybrid approach, I'm gonna do some wire bends, but from my premolars to the other side, just go with the liners. It shouldn't be a problem. So it's all about communication, doctor. Again, your technicians will help you visualize the treatment objectives, but of course, deliver the appropriate physics or biomechanics that is required for your cases, while of course recognizing that you're gonna perform hybrid approaches on another subject. Now, I'm not sure for some companies if they're gonna allow it, but as far as Sebaris is concerned, they are very much open on doing these kinds of approaches. If you say that you're gonna do hybrid, if you say you're gonna do fix on the upper, aligners on the lower, they're gonna create a custom-made simulation just for you, to ensure that it somehow matches the objective. Yeah. So I love the question. So I think that's gonna be all our questions for today. Before we end our session, before we end our session, uh, I would love to invite you guys on another Sibari starter course. So the Sibari start this case and the whole principles behind the thought processes on case selection, uh, hybrid approaches, doing it with brackets, doing it with the liners. What am I gonna do? What's my Bible? What's my perspective? We usually shed light on our starter course. So the way we do starter course, it's something different. We invest on how you do your case selection, your diagnosis and treatment planning. And then we're just gonna talk about how to deliver attachments and how to deliver all those things. So I really invite you guys to join our starter course happening on October 15 to 16. We have limited slots. We want to keep it to a small group because we want to be as intensive as possible for the doctors that we're going to be onboarding. Okay, so don't miss out. This is going to be a fun event. We just had one last September and it's a very fun event as well. So yeah. So with that, doctors, wait. Okay, so no more questions. So with that, doctors, I thank you for joining us. I thank you, Dental Tribune, for giving us the platform to share our ideas in Malaysia, in the Philippines, and all across Southeast Asia and around the world. And it has been a wonderful night. Okay, so hope to see you guys next time and good day.